session. Welcome to you, sir.
Okay, thank you. The next is about the individual factors. Pratyanga bhagnam asya vidhi atah urdum pravakshite. Now, among them, the first is Nakasandim Prishtam Raktanugatam Araya Avamatya Sute Rakte Sharibistena Lepet. In case of a fracture involving the nail bed, as such, actually nail bed is not considered as a bone and we do not consider that as a fracture now. But in case of the nail bed injuries, the major issue is about the viability of the nail and the blood clot which can form, the hematoma which is formed over there. So if there is a nail bed injury, it's better that the nail is removed and you have to prevent the blood clot, so you have to keep it open, drain it. That's exactly the principle which is mentioned by Sushruta, where in case of the Nakasandi, that the nail bed is involved, you have to ensure that the blood clot is clear by a Ara Shastra. Ara Shastra, we have discussed during the Shastra as such, that pointed needle-like instrument. With that, the clot has to be removed and ensure that that all the debris is removed, and then put a shalipista, that is plaster is placed. That's Sushruda's plaster is the shalipista. You have to immobilize. Of course, in the present day situation, you may not immobilize with the plaster. Instead, we may put a suture over there so that the bed is covered. So, nail bed has to be clear, the dry nail has to be removed. That's the basic principle, and the important is to keep it open so that there is no clot formation or hematoma formation. Now, suppose if it is the other way, like if it's a fracture involving the terminal phalanges, in the terminal phalangeal fracture, the problem would be because the terminal phalange bone is a very small bone and there is no distal support, chances of reducing that bone injury would be quite lesser. So earlier protocol of the treatment was to amputate the tip of the finger, remove the tip of the finger, so that there would be no painful tip of the finger. But in the present day situation, making this a fine wire, Custer's wire, to keep the bones together is tried. But one of the major problems in such conditions would be it may result in a painful pulp of the finger. A painful pulp of the finger is quite troublesome to the patient, and hence you have an option of removal of that. Anyway, that's about one. Then the next is Bhagnama Sandimuktvana Sthapita Angulim Samam Anuna Aveshyapattena Ghasasekam Pradapeta. In case of Anguli Bhagna or the fractures of the phalangeal bones, the Sushruta has mentioned like you have to put you keep the finger proper, position the finger proper, and with a light and small bandage, you have to put the immobilize the two fingers together and has to have Grisaseka. In the present day situation, in case of the dislocated phalangeal joints, the best of the option is a buddy bandage. Buddy bandage is making this of a neighboring finger as a support, as a splint. Instead of using a plaster of Paris splint, you may prefer the other finger as the is a splint and immobilize, and this gives a partial immobilization and good support, and the healing would be quite good. The other choices are either it could be a figure of 8 splint or a Sheffield splint is the other option to keep the fingers immobilized, but it's always considered that the body is a body bandage, or the making use of the other finger as a splint is always the better choice. Though Sushruta has not mentioned that making use of a normal organ as a part of the immobilization in case of the fingers the injury, but that kind of a principle is described in case of the Talabhagna. With that we will come to that later on. Abhyajya sarpisha padam talabhagnam kushotram ustrapatena badniyad nacha vyayamam achareta. In case of the phalangeal or tarsal bone injuries, carpal or tarbal bone injuries, metacarpal or metatarsal bone injuries, where the hastatala or the padatala is involved, one option is you have to keep them proper. It's a quite common thing, like you have to try to keep that immobilized with the vastrapatta, a black bandage is used. In case of the metacarpal or metatarsal bone injuries, it's always a chance that the chances of the dislocation or displacement of the bone is lesser, because the metacarpal or metatarsal bones are having that parallel bone structures together, surrounded by the elastic structures of the muscles and tendons, and hence the chances of the displacement are lesser. So usually we do not attempt much for the this reduction. Just immobilization with a plaster of Paris cast is preferred. In case of the lower limb, that's the metatarsal bone, the plaster of Paris cast has to be kept for at least minimum 6 weeks, whereas in the upper limb, a partial immobilization with the dynamic splinting also may be preferred as such. For the lower limb, dynamic splinting is not preferred, whereas the upper limb dynamic splinting is preferred now as a choice. That's about the fracture of the metacarpal or metatarsal bones. Then the next is Jangha Bhagna, or the fractures of the femur, the thigh as अभ्यंज आयाम यज्जंघाम ऊरुम च सुसमायितादप वृक्षत्वजशीतः वस्त्रपट्टेन वेष्टयेत. In case of the Jangha Bhagna or the thigh injury, femur involvement, Sushruta has considered many options. It's one of the option is you have to keep that thick plaster with the vrikshatvajaha, a thick splint is used, strong splint is used as such. In case of the fractures of the femur now, the issue is about the possible complications, because the femur is a long bone and a very strong bone, surrounded by very strong muscles. The muscles of the thigh are quite strong. There is always a chance of very high degree of displacement, and that once it is displaced, the bones are displaced, it is always a proximal displacement, and reduction would be quite difficult. And hence, if at all it has to be a close reduction, a continuous traction may be required, or it may be required that you may have to go for a open surgical procedure if there is a complete fracture. But if there is an incomplete fracture, and if there is not much of a displacement, as in case of a minimal injury conditions, a splintage may be enough. A splint of the thigh may be enough, but in case of the femur, usually in the majority of the patients, you require the other choice of the intervention, which also is described by Sushruta. Sushruta has described those other options also. One of the option is just immobilize, and though Sushruta has not specified that it is only in the minimal injuries, we have to take it for granted that it is in the minimal injury. Suppose in case of the urvasthi fracture, if there is a gross displacement, matman chakrayogena anched urvasthi nirgatam sputitam pittitam japi badniyat purvadvishaka. If there is a nirgata urvasthi badna, that's that there is a significant proximal displacement of the bone after the fracture, as you see, and this is very common in case of the femur injuries. This proximal displacement is the most common issue if it is a shaft of the bone which is injured, and the proximal displacement is so much that it's always quite difficult to reduce it by close reduction, and if at all it has to be by close reduction, it should be by constant traction, and the traction is again quite ingenious techniques. Traction used for the reduction of the fracture of the femur are quite difficult. You have to calculate the angles to development, these displacement has occurred, and put the weight in many directions. Skeletal tractions have to be done. You have to drive many nails across the bone, and this was the earlier preferred treatment. But with this kind of a treatment of splintage, it will be quite difficult to manage the patient, because the patient has to lie down with this splint constantly. Whatever Sushruta has mentioned is exactly the same. The chakra yoga is the splinting using skeletal tractions, where you use a pulley. Chakra is a pulley, a wheel, which is used for putting the weight. Though Sushruta has not given the description of the angles and so on, the finer details are not given, but the summary is a chakra yoga, there a constant traction is applied with a wheel. Now, of course, it could be one of the choices of the treatment in case of the fractures of the femur. But currently, because the surgery has become safer, in the present latest trend, always preferable would be a surgery, and intramedullary nail is most preferred. Though occasionally, if the surgery is not possible, this skeletal traction is still used. Earlier, some 20 years back, when the surgery was not so common, the choice of the treatment in case of the fractures of femur was the same traction, continuous skeletal traction with the splints were used as the choice. Now, of course, surgery is the choice as such. But important is the other way, that the technology of making use of the traction also was described by Sushra, though the finer details like how to put the weight and so on are not described, but Chakra Yoga is really the traction as such. Then, in case of the fractures of the hip, the Anchet Urdhvam Adhovapi Kati Bhagnam to Mano, Tata Stansthe Sando Bastibhi Sampadre. In case of the hip injuries, the Sushra has suggested about pulling the patient's body in both the directions, in the superior as well as inferior direction. So somebody has to pull the patient up and down, and this is one of the technique which was practiced in those days to keep the bones in stretch, like the traction in that direction is given. Now, of course, and plus anesthesia sando bastibis sumapatharetu, then basti is given in case of the pelvic bone injuries. Now, in case of the pelvic bone injuries, now they usually, of course, with the pelvic bone injuries, there is always a risk of intra-pelvic injuries, pelvic organ injuries, and the bleeding occurring over there, and it's a very high risky condition, and hence surgery is usually preferable. Open surgery is preferable now. But suppose if the open surgery is not required and you have a relatively stable injury, then a spica is now preferred. In adults, the spica is preferred. Spica which keeps the legs somewhat partially abducted with a support on both the legs, and the spica extending up to the chest is used. Of course, you will have some openings, letouts for the physiological evacuations, the bowel and the urinary evacuation. You will have to have some opening. Then, in case of the children, there is another technique which is also called as guillotine technique or guillotine splinting, where the leg is kept elevated, one leg is kept elevated, and a unilateral spica is preferred. Now, the important basic principle is you have to ensure that there is a continuous traction in both the directions. To help that traction, you keep the hip elevated by putting a sandbag over here, so that the weight on the proximal part of the body and weight on the distal part of the body would be acting in the opposite direction, and hence the traction is given. So we make use of, now in the present day situation, the weight of the body as it is used as a traction. Sushruta has suggested to make use of the same with somebody helping or some assisted pulling the patient's body apart, which looks somewhat odd. Now, if you say that the same technique has to be followed, now it looks odd. But the principle, the dynamics of the treatment is the same. Like you have to ensure that the body weight on both the sides would be acting as a constant traction, and the hip is elevated to achieve a proper reduction of the hip bone. So that's about the Kati Bhagna treatment. Then, in case of the fractures of the ribs, Parshakasu Athabhagnasu, Ghasabyaktasthitishthadaha, Dakshinasu Athava Vamasu, Anurujya Nibandhanihi, Tatak Kabalikam Tatva, Vestayet Susamaidaha, Tailapurne Katahava, Dronyam Vashayet Naram. Now, in case of the fractures of the ribs as such, Sushruta again has two options. One, just immobilize the bone with the after manipulating, after pressing over the area with a kabalika, a bandage kept over there. If the injury is severe, then the patient is kept in a Tailapurna Kataha or Droni, a boat-like instrument or vessel, where the patient's body is kept dipped in a oil as such. Now, this principle also has certain basic physiological principle, though now we have a lot of technological modifications. In case of the fractures of the bone, the fractures of the rib, we classify them into two conditions. A stable rib injury where the fracture is at only one side and the chest wall is stable. The patient is able to breathe in and breathe out. And in such conditions, the treatment is usually simple, where you put a simple plaster of this adhesive plaster, leukoplaster or some adhesive plaster across the area of the injury, and that gives a partial immobilization, and that would be enough to keep the bone together and the patient would be fit. But the other way is if there is a serious or rather multiple injuries and it has resulted in a penetration of either the lung or the thoracic cage, a open injury, it results in a flail chest movement. The flail chest movement is, usually during the inspiration the chest expands and during the expiration the chest constricts. Now the whole chest would be having that kind of a movement. In case of such multiple fractures of the ribs, the area of the fractured bone would not be moving along with the respiratory movements. So when the whole chest expands, that area where the fracture has occurred may not expand, it may remain depressed. So it looks as if that's getting depressed. And when the breathing out during the expiration, as the chest recedes, that area doesn't again recede, it looks like it gets a bulge. So this could look like a paradoxical breathing. It's not real, flail chest movement is not a paradoxical breathing, but it gives an appearance of a paradoxical breathing, and that condition is always critical, where the patient may have a pneumothorax or a hydrothorax or hemothorax. The bleeding may occur, and there could be a continuous compression of the lungs, and the patient may have a risk of particularly pneumothorax where the air is being sucked in. And in such conditions, the primary treatment would be drainage. Thoracic drainage has to be done. Now, once you have done the thoracic drainage, the tube that has to be kept dipped in a water or some other solution so that the air is not sucked in during the inspiration. So now, in the present day situation, when there is an open wound in the thorax, we connect that wound to a tube, and the tube is dipped in oil or maybe a fluid, usually sterile fluid as such. Sushruta didn't have this technique of a tube. Instead, Sushruta suggested to keep the whole patient's body in a tub of oil so that the pneumothorax wouldn't occur. Now, so the only difference now is we have made the whole concept of preventing the pneumothorax by having a watertight compartment or maybe a layer where the air cannot enter in. Is done now by making use of a tube which is dipped in water. The purpose of keeping that water or solution is to prevent the air from being sucked in. Whereas Sushruta had used the idea of keeping the body dipped in oil. So principle remains the same, but now the procedure has been made more convenient and more effective by making use of a tube. Whereas Sushruta method looks like a crude method which may not be applicable exactly as such, but adopting that principle holds good. So that's about the fracture of the ribs. Then comes the issue of the fractures of the shoulder, injuries around the shoulder, dislocation of the shoulder. In case of the dislocation of the shoulder, Sushruta says, Musalena utkhipet kaksham amsa sandhausham hare sthanastitantyapadnyat swastikena vichaksharaha. Musala is the pounding rod, onake. It has to be used to lift the area of the arm and the shoulder, and then the bone has to be placed in. Now, in case of the shoulder joint dislocation, of course, we classify them into different types like anterior, posterior, and there again you have subluxation injuries and subcoracoid and subclavicular, depending upon the position. That makes the issue of the dislocation somewhat more complicated. To make it generalized, the most simplest generalized issue of the reduction of a shoulder joint dislocation, and quite important, is you have to initially start with the initial step of the traction. The patient has to keep the elbow somewhat flexed, and then there is a continuous traction given With the continuous traction given, initially the arm has to be externally rotated, and then after the external rotation, keeping the arm abducted, bring the palm towards the opposite side of the shoulder, and during this movement the reduction would occur. But at times the reduction would not occur with that. In such conditions, to facilitate the reduction, you have to ensure that the axilla, the gap in the axilla is widened by keeping a soft structure, or at times you may have to keep a cloth and then somebody has to pull it apart. This is again a standard technique, and the same maneuver is repeated. And with this, that leverage given at the axilla to keep the bones apart and get a gap between the acetabulum and this head of the humerus and the acetabular surface, the issue is so that there could be a reduction, facilitated reduction, and this is the technique. So key in case of the reduction of the shoulder is to ensure that there is a gap between the two bones. Now Sushruta had used a musala, a hard pounding rod, to achieve that gap. It's not that with the pounding rod this area is hit. Some translation books will say that with these pounding rods the area has to be hit. It's not about the hitting. Sushruta has suggested to make use of that rod as a leverage so that the gap is enhanced and the reduction is possible. A reduction is facilitated. Now we may not use a pounding rod, we may use a soft pad or maybe a cloth and with the traction, so that it looks somewhat more sophisticated, but basic idea of the dynamics is the same, like you have to achieve a proper space for the reduction. Then in case of the kurpara sandhi, the elbow joint area, kurparam tu sandhim angustena anumardayet anumurjyata sandhim pidayet kurparachyutam prasarya akunchayachinam sneha saikam jadapayet evam janani gulpecha manibandhe chakarayet. With the elbow joint, the most important issue is the delicate olecranon process here. The olecranon process is that very thin bone, and when it is dislocated, particularly when it is posterior dislocation, this would be entitled at the supratrochlear notch, that notch between the above the trochlea, and once it gets entangled in the supratrochlear notch, the reduction becomes difficult. And if anybody attempts to reduce with somewhat strength as such, this bone may get broken. A fracture induced during the treatment, fracture of the olecranon process induced during the treatment would be always a dangerous issue. And hence, in case of the elbow joint dislocation, it's always said that you have to try to do the procedure of reduction very delicately. And delicate handling is the most key issue. Of course, if it is a third degree injuries where there is a divergence of the radio-ulnar joint also, then virtually the close reduction is not possible. Whereas in a posterior and anterior dislocation, close reduction is possible. Lateral and the divergent dislocations, close reduction is not possible at all. Now the technique, the important is being delicate about that issue. So initially you have to put a pressure over the area, dislodge the olecranon bone, and then try to reduce. That's the basic issue. And that is done with delicate, with the thumb and finger manipulation, external manipulation, which needs a lot of experience. Now, what exactly Sushruta has mentioned is the same. Angustena anumardayet. You have to delicately handle that area with the angusta, and then once it is reduced, then the issue is it's a partially immobilized with a sling. Usually, a sling is suggested, and Sushruta also suggests same sneha saikam jadapayet. And the proof of reduction is achieving a complete range of the movement. Prasarya akunchayatyenam. With the prasarana and akunchana, extension and flexion, you have to control that. Now, I said about the body bandaging technique used by Sushruta. In case of the Talabhagna, one of the options, one option was mentioned earlier in the earlier shloka, where the Talabhagna, that the fractures of the metatarsal or metacarpal bones are immobilized with the splinting. The other option is Sushil suggested. Ubhetale Samekritva Talam Nursidehina Badniatam Telena Parishekam Chakarayeta. In case of the Talabhagna, make use of the other hand or other limb as a splinter. Now, that idea of making use of a normal part of the body as a splinter is a really breakthrough in the management of the fracture. And that's always considered as a best option for the splinter because it's a normal physiological structure which has otherwise the same configuration anatomically. It gives good support and as well as it doesn't really result in a complete immobilization which can result in adhesions. So wherever possible, making use of the normal part of the body as a splintage is always a preferable treatment, and this can be done very easily in case of the injuries of the fingers, whereas injuries of the palm or the other way may not be practically possible now. But Sushruta had suggested that in case of the palm or the plantar surface, which may not be practicable, but the important is the principle of making use of a normal part of the body as a splintage is one of the major contribution of Sushruta in management of the fracture. Then comes the idea of the physiotherapy. Once there is a fracture of the palm or the area, there is always a possibility of the rigidity, and to get over the rigidity, Sushruta has suggested a training of the hand after the fracture has united by gradually increasing the load. And that increasing the load, the models given by Sushruta are Mritpindam Tahare Purum, Lavadam Chatura Param, Haste Jatabale Cheva Kuriyat Pashan Dharanam. Initially, the patient is suggested to hold or squeeze a moist ball of mud which would be soft and then which doesn't require more weight. Then once the patient is able to do that, the next part would be you give a ball of salt which would require more force and then press it. And once that also is achieved, that kind of a strength also is achieved, then go for Pashanadhara. A hard stone is held and then squeeze it so that the maximum strength is gained. The whole concept of the physiotherapy or rehabilitation in case of the fracture management is exactly the same. Once the joints the bone has become capable of bearing the load, to make the bone and make the joint functional, there is always a need to gradually increase the load. If you suddenly increase the load, there is a possibility of more complications. And to gradually increase the load, now you have many instruments, machines, so on, springs and so on. Now you have even more calibrated machines. But the whole basic principle of the physiotherapy is ensuring that there is a gradual increase in the load and gradually enhancing the capability of the organ. And that's exactly what Sushruta has suggested. Though the materials or instruments used by Sushruta look primitive, whereas now you may have more sophisticated instruments where everything is more objectively graded, the amount of the energy required also can be objectively graded and controlled. That's the advancement of the technology, but the basic primary idea of the physiotherapy is the same. Then next is Akshakasivadna or clavicular fractures. Sannam Munnamayet Swinnam Akshakam Musalenatu Tata Unnatam Pide Cha Badniya Gadhameva Urvachapi Kartavyam Bhagnachitsa. Now Akshakasivadna or clavicular fractures, from the in case of Sushruta description, the depressed portion of the clavicle has to be elevated again with a leverage of musala, as in case of the shoulder. Here also the musala or that pounding rod is used as a leverage, and then you have to put a gardabandha, a rigid bandage is used. Now the general principle in all cases of the fracture is used to a samabandha, but in case of the clavicular fracture, Sushruta has suggested a gardabandha. Now in the case of fractures of the clavicle, as we see now, the clavicle fracture could be of two categories, the distal 1/3 and the proximal 2/3. The proximal 2/3 fractures are always high risk conditions where there is always a high possibility of accompanying injury to the pleura or the lungs, and they are considered as a condition which require a multidisciplinary approach. If there is a possibility of injury to the lungs, you need to have a multidisciplinary approach. But in the distal 2/3, distal 1/3 of the fracture injuries, and which are more common, the more common are the distal 1/3 of the fracture, the displacement would be superior, and usually they can be easily managed with a simple bandage, usually a figure of 8 bandage, or maybe a bandage with the support of the chest. You have different forms of such bandages, like the technique of putting the bandage in case of the fractures of the clavicle. You may have any of these preferred techniques depending upon the intensity of the pain and the displacement. Simplest is a figure of 8 bandage, which is more commonly preferred, which keeps the shoulder extended, partially, slightly extended, and that would be enough to immobilize, and the union is a rule. So it's a relatively simple fracture from the other point. But even if there is a malunion, it doesn't really affect the function significantly, and hence it's usually preferred to be managed with a close reduction. But if there is a need for cosmetic appearance to be correct, like if there is a malunion, there would be a projection over there, and to avoid that, surgical treatment may be preferred now. But the usual choice of treatment is close reduction, and there again the principle is to very simple, making this a figure of 8 bandage to add a leverage in the shoulder. See, when you use a figure of 8 bandage, the gap in the axilla would be increased. What Sushan has suggested is making use of a pounding rod to achieve this gap, but not constantly. That's the issue. As then ग्रीवायां अत विवृत्तायां प्रविष्टायां मधोऽपि वा अवटवदहन्योश्चां पुरुष्य उन्नमेन्नरं ततः समां दत्त्वा वस्त्रपट्टेन वेश्चेत् उत्तानं शायेत्येनं सत्तरात्रं मतन्दितः. In case of the fractures of the cervical vertebrae, injuries of the cervical vertebrae, the immobilization is done by extending the neck. To extend the neck, Sushil suggested like somebody has to hold the chin and the occipital area of the patient and lift up so that the neck is extended, and in that extended neck position put a splint around the neck and a bandage has to be placed. Now this looks again odd. If you try to lift the chin and the occipital area of the head by somebody else assisted, it looks very odd. Whereas now we have different sorts of the cervical collars. The cervical collars, the basic principle is keep the chin extended exactly avato hannoshta pragrishya, so it has to be elevated, and the vertebral bodies are kept stretched so that there will be no neuronal compression. So in case of the vertebral body injuries, unless there is a gross spinal cord pathology, the conservative treatment would be always making use of a cervical collar. The other option, of course, is surgical. Even after surgery, the patient is kept in an immobilized position with the cervical collar, and the cervical collar principle is the same, that neck is extended and you will have a support at the chin as well as at the occipital area, and keeping the neck extended would increase the gap between the two bones and prevent the compression of the nerve roots, and that's exactly the principle which is used by Sushruta there. And to prevent further displacement, patient has to be kept in a supine position for 1 week. Saptaratram atandrita uttanam shayed should be in the supine position only. Then in case of the mandibular dislocation, hanmastini samaniya hanusandhau visamhate sevadayitva sthite samyak panchangim vitaret bhishaka vatagna madhurehi sarpe siddham nasyeti pujitam. Dislocation of the mandible is a very frequent injury which occurs during simple innocuous movements like laughing or stretching or yawning, etc. And you come across that quite frequently in a patient who have neurological pathologies. In bards where the patients with the paralysis or so on are treated, this kind of an accident usually occurs. And what Sushil has suggested is you have to manipulate very carefully. Samaniya is with careful handling, the bone has to be placed, put back, and then put a panchangi bandha, a bandage which supports the chin and keeps the chin closed. Now, and then of course you have to give the nasya and Bhatagna Madhurei Sakpihi, Krita also has to be given. Now in case of the fracture, dislocation of the mandibles, the important technique of management is never try to close that. See, once the mandible is dislocated, patient is not able to close the mouth is kept open, And in that condition, never try to close the mouth by putting the pressure on the chin. Instead, you keep your finger into the mouth and press down at the second molar tooth, and that downward displacement would make that neck of the mandible, that stylus of the mandible, uh, coming back to its pouch, that the maxillary pouch over there, or maxillary fossa over there. If at all this is not done, because the neck is a very delicate structure, it may get fractured. If you attempt to close the mouth by putting the pressure on the chin upwards, it may result in a fracture. So the precaution has to be taken. It should be always a downward pressure at the second molar tooth, and then once that is displaced, the whole mouth has to be reduced, and you may use exactly the same. The technique is the same. A Panchangi Bandha, exactly the similar bandage is used, and this bandage would have that 5 limbs or 5 wings as such, as Sushruta has suggested. So Panchangi Bandha is used as such. That's the principle of reduction of mandibular dislocation. Then in case of the teeth injuries, Sushruta had considered teeth injuries under the diseases of the asti, whereas now the injuries of the tooth are in the area of domain of the dentistry, not that of the orthopedics. But still, we have to have a fair idea of how it is done. Sushruta has suggested, like, if the teeth injury has resulted in a partial injury where the tooth is not completely displaced and the vascularity of the tooth is maintained, and if the patient is a relatively younger patient, you try to conserve, try to salvage the teeth, keep the teeth intact, keep the teeth back into the socket, and then apply Shitalepa and make Sandhaniya Dravya are to be given, so that there will be a recovery, the tooth would recover. So vascularity is the important issue. Abhagnan, Chalitan, Abhagnan, which are not really broken, but Chalitan, if they have get mobilized, Dantan, Saraktan, as long as there is a bleeding there, अवपीडयेत् तरुणस्य मनुष्यस्य शीतैः आलेपेद्भिः सिक्त्वा अम्बुभिस्ततः शीतैः सन्धानैः उपाचरेत् उत्पलस्य नालेन क्षीरपानं विधीयते. Now once you have kept the mouth closed and then put a tight bandage over the teeth, patient is not able to feed, and to feed Sushruta had suggested to make use of a Utpalanala, a tube of water lily plant as a feeding tube. So idea of feeding tube also is described by Sushruta. The only thing is, because he didn't have a plastic at that time or any other synthetic substance at that time, he had used a naturally available stem of a water lily plant as a feeding tube. Now, of course, we have synthesized feeding tubes which are much safer, much stronger and durable. So definitely, yes, they are better. But principle of making this a feeding tube is important. Then the next is, if the patient is very old, Jirnasya Manushya Varjayat Chalitan Vidan. If the patient is very old and salvaging the tooth would not be possible in that condition, it's better to remove the tooth. Then Nasam Sannam Vibruktam va Ridvimva Krutva Shilakaya Kritam Naskayo Nadyo Dimukho Sampraveshet Tada Pattena Samvestya Ekam Pradapayat. Injury to the nasal cartilages is another of the common injury which occurs even now accidentally, whereas in Sushruta period this was one of the part of the techniques of punishment, where the nasal bone would be cut, as such as nasal cartilages would be cut. So in such conditions, Sushruta suggested to try to keep that the structures in the proper position by having a mold which is hollow. A tubular mold is kept in the nose, and then the patient is immobilized with the tube. Even now, in case of a minimal injury where surgery is not required, the same is preferred. You keep a rigid mold, usually a fiberglass, and then the same position is the torn cartilage is placed over and they put the bandage. Of course, if it's a very gross injury, then you may have a surgical resuturing as an option. Then Bhagnam Karnam Tadnyatu Sam Krutva Krisapludam Sadekshata Vidhanam Tatra Paschat Samacharet. In case of injury to the pinna of the ear, we have already discussed in Karnameta Bandha and earlier also that the whole torn, and in case of the Chinnamrana also we have referred to the issue. There is an attempt to try to immobilize or re-establish that pinna of the ear and then suture as a choice of the treatment. As we have discussed earlier, in the present day situation, you may have different types of the molds and processes which are used there. Then in case of the head injury, Mastulunga Vinabhine Kapale Madhusapishi Dharpa Kapa Nibadniyad Sapaham Vivek Dhrutam. Now in case of the skull fractures, the important issue is whether that skull fracture is simple linear fracture or depressed fracture or basal, where there is a fracture of the basal area. The complications and issues would have to be dealt with in a different manner. In all the conditions, it's quite important that whether you have to confirm whether the intracranial injury has occurred or not. Integrity of the intracranial structures, the brain and nervous system as a whole, possibility of the complications like subdural hematoma in case of a fractures of the skull, they are quite significant and they have to be assessed energetically, confirmed, and then only the issue of fracture management comes in. Now, what Sushruta has suggested is if there is no such injury to the Mastulunga, there is no evidence of brain injury or any sort of the complications of brain, then keep the bones together over there and put a band-aid. That's absolutely true. In case of the absence of intracranial injury, management of the fractures of the skull is there is no need of much reduction, because you have, if it is only one diplo, see, bones have two layers, diplos. If one diplo is involved but there is not much of a depression, then just put a bandage and the usual pain management. There is no need of any other real surgical intervention or the other rigorous intervention. If it is a depressed fracture over the scalp, then that depressed area has to be elevated with a burr hole. You have to make an opening there and then lift up. But the fractures of the basilar area, the floor of the brain, there you have a major risk, because those bones in the floor, the vomer and the other bones there, they are very delicate. There is always a possibility of leakage of the cerebrospinal fluid and coning effects. The whole brain may be compressed and can result in very serious fatal complications later on. So though at the time of your evaluation there may not be any cranial injury, but if there is a fracture of the basilar area, then there is always a potential risk of the later coning effect, and hence that has to be handled very carefully. And though it may not require a direct intervention, the methods to prevent the leakage of the CSF have to be taken care of, and the best method is to keep the head end lower till the gap is sealed. So that is the option, but that has to be kept in mind. Then a general principle of treating a patient with the soft tissue edema produced due to the trauma. Due to the trauma, there could be a swelling. Swelling could occur due to two reasons: either there could be hematoma or there could be the inflammatory edema. Now, in case of the hematoma, like or bleeding at the site, that can be prevented by cold poultice. If there is an inflammation, then you have to use the hot sponges. Hot or the cold sponges are preferred depending upon the stage in which you see the edema. Now, Sushruta has suggested in such conditions, Patanad Abhigatadva Shuna Mangam Medakshatam Shitan Pradehan Sekansha Bishak Tasyavachareta. A cold application is preferred. Now also it is the same in case of a trauma. The preference is the same: rest, ice, compression and elevation, which is called also the rice method of injuries. Then अथ जंगोन्मग्नानां कपाटशयनं हितं कीलकाः बन्धनार्थं च पञ्चकार्याः विजानता यथा न चलनं तस्य भग्नस्य क्रियते तथा सन्देहे उभयतो द्वौ तले च एकश्च कीलकः. A fracture bed is the other option, though now we may not use exactly the fracture bed in the bar conditions in the treatment, but fracture beds are used in the operative procedure. The whole idea of the fracture bed is to keep the bones together, keep the patient's body fixed. You will have to have some supports, rivets, which can be moved, and that moving rivets around the area can help the patient keep in a fixed position. Sushruta has suggested 5 rivets which can be moved up and down. Even now, the fracture bed would have a similar issue, similar structure, though there could be more technical sophistication. So that's about the fracture bed used by Sushruta. श्रोण्यां वा पृष्ठवं सेवा यक्षस्य यक्षकयस्तदा बध्नसन्धिविमेक्षेषु विधिमेनं समाचरेत्. A fractured bed can also be used in case of pelvic injury or injuries of the vertebral body, or even case of the thoracic injuries, the fractured beds could be used. One of the complications of the fracture would be the contractures developing, and that's exactly what Sushila has mentioned as a chiravimukta sandhi, a sandhi in chiravimuktamsa, a joint which has become rigid after the surgery, after the handling of the fracture. That has to be managed with a gradual snehana and svedana and ensure that it has become softer. A gradual manipulation is suggested. Of course, the workman's contracture, which is a complication of the fracture, now is a very serious issue, and it occurs due to the damage to the nerves as well as the vessels. Whereas there could be some adhesions. Adhesions can be easily separated as such. So adhesions can be separated easily, whereas contracture which has occurred cannot be easily separated. But for the adhesions, it's exactly the same treatment, like you have to have some fermentation and then maybe a gradual breakdown of the tissues there, and that can recover. But once the contracture has occurred, it may not be possible to make the structure recover easily. Then a malunited fracture. Kandabhagne prarudetu vishama ulbadsamhate apotthya samayet bhagnam tato bhagnamadacharet. If there is a fracture which has occurred or united in a abnormal manner, malunited fracture has occurred and there is a anatomical deformity at that area, then Sushila has suggested about refracturing the area and then again try to unite the bone in a proper manner. Now also the treatment is the same, but the only issue is now for refracturing you need to make use of all the technologies like CT and so on, three-dimensional CT, and exact point where you need to have the refracturing can be calculated by assessing the deformity, and hence you can have a better result, whereas Sushila doesn't mention about that sophistication for the refracturing. But the principle of the management of a malunited fracture is the same. Then in case of a compound fracture with a bone projection, of course, Savrana Bhagna we have already referred to in the beginning, where Sushila suggested that the priority to the treatment should be to the wound first and then the bone. But whereas another variety of the Savrana Bhagna where there is a projection of the bone, Kalpayet Nirgatam Shishkam Ranante Asthi Samahida Sandhyate Vakriyam Kuryatu Savrana Bhagna. If there is a projected bone outside, that's the grade 3C compound injuries. That compound injuries and their grade we have discussed in the previous sessions, so you remember about that. In such conditions, the treatment Sushila has suggested that projected bone has to be chopped off and then the area has to be reduced. Of course, even now the principle of the treatment is same, that the area of the bone which is not viable has to be chopped off, but the gap has to be now filled with the bone graft, whereas Sushila has not mentioned about the graft as such. Then the general other principle are Urdhvakayet Bhagnanam Masishkyam Karnapurnam Ghasapanam Hitam Nasyam Prashakhasu Anuasanam. In the fractures of the upper part of the body, Karnapurana, Masishkya, that's Nasya or Ghasapana are preferred, whereas the fractures of the lower limb, Anuvasana or the other bastis are usually preferred. Then Atamurdham Prakshami Tailam Bhagna Prasadakam. One general yoga which is used for the Bhagna treatment is suggested by Sushila. Preparation of this yoga is very complicated and it's a very costly process. So it's used for only the kings as such, whereas there is another yoga which is also for the common man. Now that yoga which is preferred for the kings or more superior yoga, which is also called as Bhagna Prasadaka yoga or Gandhataila, it's also named as Gandhataila. And very interestingly, even now in the market there is a product available in the name of Gandhataila, but that Gandhataila is totally different from the Gandhataila mentioned in Sushila. The Gandhataila which is available in the market is totally different from the Gandhataila which is mentioned by Sushila. And the yoga of Gandhataila mentioned by Sushila is Ratro Tilan Krishnan Basayat Asthirejale Diva Diva Shoshayitva Gavam Chirena Bhavayetu Triyam Satparatram Tu Bhavayet Madhukamana तथा क्षीरं पुनः पीतान् सुशुष्कान् चूर्णयन् विषक् काकोल्यादीन् सर्यश्चाहं मञ्जिष्ठां सारिवां तथा कुत्सं सर्जरसं मांसीं सुरदारुं च सचन्दनं शतपुष्पां च सञ्चूर्ण्य तिलचूर्णेन योजयेत् पीडनार्थं च कर्तव्यं सर्वगन्धश्रुतं पयः चतुर्गुणेन पयसा तत्तैलं विभजेत् विषक् एलाम् अंशुमतीं पत्रं जीवकं सकलं तथा रौद्रं प्रपौण्डरीकं च तथा कालांसारिवं सैरयकं क्षीरशुक्लाम् अनन्तां संसूरिकां पिश्वा शृङ्गाटकं चैव पूर्वोक्तानि औषधानि च एभिस्तद्विपचेत्तैलं शास्त्रविद् मृदुनाग्निना एतत् तैलं सदा पथ्यं भग्नानां सर्वकर्मसु आक्षेपके पक्षाघाते कालुशोषे तथा अर्दिते मन्यास्तम्भे शिरोरोगे कर्णशूले हनुग्रहे बाधिर्ये तिमिरे चैव ये च स्त्रीषु स्वयं गताः पथ्यं पाने तथा अभ्यङ्गे नस्ये बस्तिषु भोजने ग्रीवास्कन्द उरसां वृद्धिः अमुनैव जायते सुखं मुखञ्च पद्मप्रतिमं ससुगन्धिसमीरणं गन्धतैलमिदं नाम्ना सर्ववातविकारणं राजास्त्वम् एतत् कर्तव्यं राज्ञामेव विचक्षणैः गन्धतैल preparation is done by making use of the tila, and the tila has to be kept in water, moving water, flowing water at night, and then again in the daytime it has to be dried up, and this has to be done for 7 days, and then again for 7 days the same procedure is done with the milk, and then with the kashayas of different drugs, and then you have plenty of other drugs added, and taila is prepared. And that taila would be used for many other disease conditions also, not only the fracture, like conditions like akshepoga, pakshagata, talushosha, manyasamba, shiroroga, karnashula, etc. In those conditions also used, and they are used for, the taila is used for through all means like patyam, pane, tata abhyange, nasya, bastif. It can be given by oral route or over the applied over the area, or can be given in the form of nasya or the basti. And by regular use of the taila, the body built would be better. Rivas kandorasa muddhi, the neck and shoulder, they become quite hypertrophic, and the face looks like lotus, and the platters you pass would be having pleasant smell. That's for the Rajas, kings. For the other poor people, the other option is Trapusa Akshapriyadanam Tailani Madhurai Saha Usam Dattva Yathalabam Kshire Dashagune Pached Snehuttamam Chashu Kuriyat Bhagna Prasadan. Another Bhagna Prasadan Taila, which is a relatively simple yoga, which also can be used in the similar manner, Pana Abhyanjana Nasyeshu Basti Karmani Seta. Now the last is in all that priority of the management of the factory is to ensure that there is no pus formation. Paka should not occur. Paka is a choice of option in case of the Bhagnachitsa, whereas in the Bhagnachitsa, Paka is not a choice, it's considered as a complication. We had prior discussion about the issue of considering that the suppuration as a sequelae or the complication. Sushruta had both the views. Sushruta had a view of considering that Paka as a complication in case of the Bhagna, whereas in the other Pranashopa, it's considered as a sequelae, which is more rational approach. Anyway, in case of the Bhagna, Bhagnam naiti yathapakam prayetetu tathabhishak pakkumansa sirasnayu tadhikrichrena siddhati. You have to ensure that the pus formation doesn't occur, and you may use any means to prevent that. Then the proof of a complete healing, proper healing of a fracture is a Bhagnam, Sandhim, Anavidham, Ahinangam, Anulbanam, Sukha Chesta Pracharam cha Samhitam Samyagadisheta. When a bone at the end of the treatment is having no anatomical deformity and has all the normal functional capabilities, and there is a comfort of all the range of movements, then you have to consider that the fracture is healed or inactive. With this, the chapter is closed. Sushruta Samhitam Chikitsa Sthane Bhagnachitsa Nama Tritiyodhyayaha. That comes to the end of it. If there are any questions, we will try to answer. There are some questions. What could be the purpose of Ghrutapana for 7 days? That is to ensure that the patient is having a proper nourishment. Ghrutapana in case of fracture would be particularly when the patient is not able to take orally the full volume of the blood, volume of the food. You have to give a concentrated food, and Ghruta is one of that concentrated food. The same idea is in case of the Gristic Shira with the Susarpishka. Gristic Shira with the ghee also is suggested in the similar manner, similar idea, where a dietary rich food, nutritionally rich food is given. I think that could be the option, right? With that, we will conclude today.